Good morning, everyone. This is day 4 of training. I'm glad that you're all here today with me. My name is Victoria Russo. I am the SSI subject matter here on the protocol and validation team at NHSN, and I'm happy to be here today to present the 2019 SSI presentation. And this is just a reminder that SSI surveillance isn't that bad. It can always be worse. This is my dog Peppy. Right now, he has a cone around his head, so he's not very happy. It's going to be a long presentation, so we'll try to get through it and have as much fun as we possibly can. We'll take a break at 9:30 for about 15 minutes, and then we'll resume from 9:45 to 10:45. So we'll go ahead and get started. So throughout this presentation, we will review what you need to know to be most successful when performing SSI surveillance. Our goals for today are to understand the burden of SSI, to locate SSI surveillance resources, to review SSI definitions, key terms, reporting instructions, and frequently asked questions. Also, we want to review the different data fields on the SSI event form, as well as the SSI denominator for procedure form, and accurately apply the 2019 SSI protocol through knowledge checks. Additionally, I will call out some protocol updates. There wasn't any significant updates to the SSI protocol for 2019, but I will call out some updates that did occur throughout the presentation. As a reminder, there will be an SSI surveillance and analysis group exercise today, but it's after lunch from 1 to 1:30. And another reminder, just to supplement your training today, you'll want to have Chapter 9, the SSI protocol, and additionally Chapter 17 protocol as well, the surveillance definitions for specific types of infections. Okay. So what is the burden of SSI and why do we perform SSI surveillance? Why is it so important? We know that SSIs are a substantial cause of morbidity, prolonged hospitalization, unplanned readmissions after surgery, and death. It is estimated that 157,500 SSI infections occur in the United States every year. SSI is the most costly HAI type with an estimated annual cost of $3.3 billion and is associated with nearly 1 million additional inpatient days. We know that the number of operative procedures performed in the United States continues to rise, and there's an increase of complex comorbidity seen in surgical patients. It is estimated that approximately half of SSIs are deemed preventable using evidence-based strategies. So where do you look for SSI resources? I'm going to go through a couple places where you could locate some SSI surveillance resources. And I want to briefly point out the NHSN educational roadmaps. How many of you are familiar with the roadmaps? Okay, so some of you not. So these are the NHSN educational roadmaps are available on the NHSN website as a resources for users that are new to NHSN. The roadmaps provide a guided tour of the training materials and information needed for a solid foundation, from the basics to more advanced training into analysis for each individual component or protocol. So I've highlighted here just the SSI areas specific to SSI just for your own information. So if you haven't heard of these or if you're new to SSI surveillance, definitely want to check these out. Now, under materials for enrolled facilities, highlighted on the left-hand side here, you will find the main SSI webpage. I'm sure most of you have been here. But once you click on more, it's going to take you to what I like to call the SSI landing page. And this is where you're going to find your resources for those users that are enrolled into NHSN. You have your training tab, which actually will be, this presentation will actually be loaded here. So the 2018 presentation is on there currently. The current protocols for 2019, frequently asked question documents, so your SSI FAQ as well as your operative procedure code FAQ documents and the miscellaneous FAQ documents, data collection forms, so your numerator and your denominator for procedure forms, your CMS reporting materials, supporting materials such as your operative procedure code documents, and then any analysis resources that you may need. Now, Kathy talked about these on Monday, but I wanted to briefly acknowledge the NHSN HAI checklist, and these are found under materials for enrolled facilities. These are modeled after the Tennessee Department of Health checklists, and the purpose is to supplement your surveillance activities, to provide a tool to assist IPs when making a determination about an HAI. Now, it's not a requirement to use these checklists, but some people just like a checklist format. I do. I think it's easy to work through a case this way. But just remember, if you do use these checklists, that you want to have your protocols as well with you, because there's a lot of additional reporting instructions and information that you'll want to refer to from the protocols. And this is just an example of the SSI checklist. There's the superficial incisional, deep incisional, and organ space SSI. And then there's also, for SSI, for the organ space SSI types, there's the site-specific checklist as well. So they're pretty handy. And then finally, I want to note that sometimes we get questions from users asking about prior protocols from prior years. And actually, under the Data Validation Guidance tab here, you will find protocols that are from previous years. So for SSI, you definitely want to use the protocols and guidance documents that correspond with the year of the operative procedure. So for example, if there was a COLA procedure performed in 2016, you're going to want to refer to the 2016 documents, or 2018 for a COLA procedure, the 2018 documents. Okay, so now let's talk about SSI reporting and surveillance methods. Now, surveillance of surgical patients can occur in any inpatient facility and or hospital outpatient procedure department where the selected NHSN operative procedures are performed. To perform SSI surveillance in NHSN, you must follow at least one NHSN operative procedure category that is included in an ICD-10 PCS and or CPT NHSN operative procedure code mapping as indicated in the patient safety monthly reporting plan. And remember that you must have a monthly report. You must have a reporting plan for every month of the year. You want to collect SSI event, also known as numerator, and operative procedure category, also known as denominator data, on all procedures included in the selected operative procedure categories that you indicate on your monthly reporting plan. Please note that SSI surveillance in ambulatory surgery centers and ASCs should be performed using the new outpatient procedure component, or the OPC. The OPC replaces the use of the SSI protocol for ASCs. Now you will get more information about regarding the OPC. There's a presentation this afternoon. Well, let's discuss a few more SSI reporting requirements. It is important to note that a procedure must meet the definition of an NHSN operative procedure to be included in SSI surveillance. All procedures included in the monthly reporting plan must be followed for superficial incisional, deep incisional, and organ space SSI events. The type of SSI reported must reflect the deepest tissue level where SSI criteria is met during the surveillance period. Remember that SSI events are reportable by the facility where the procedure in which it was linked was performed. I think I'm too short. I was just trying to hide. Thanks, Kathy. And only data included in plan will be used by CDC in aggregate data analysis. I do want to state that although NHSN only sends deep incisional SSI events and organ space SSI events for colo and HIS to CMS, you must still report all SSI events to NHSN. And likewise, SSI events where PATOS equals yes must be reported to NHSN, even though they are not sent to CMS either. And we'll talk a little bit more about PATOS later. So we get this question from time to time. What NHSN operative procedures am I required to report? Well, the answer is NHSN does not mandate reporting. NHSN is simply a mechanism for data you enter based on what you select on your monthly reporting plan. And what you have in your monthly reporting plan may depend on your facility internal risk assessment, any state or CMS required reporting, or any other required reporting by other organizations. Now, if you're not sure what is mandated, I'd recommend you contact your state HAI coordinator to ensure you're complying with any requirements in place. It is important to note that SSI monitoring requires active patient-based prospective surveillance. While NHSN does not dictate what methods you must use when performing SSI surveillance, the expectation is that the methods used would identify all SSIs that occur. There are different ways to perform SSI surveillance within your facility, including review of medical record or surgery clinic patient records, such as the admission records, the readmission records, ED or OR logs, patient charts for signs and symptoms, look at your labs, look at your imaging, other diagnostic test reports, review clinician notes. Also, ICD-10 CM infection diagnosis codes are helpful to review, to prompt further review to determine if an SSI is met. Don't forget to visit your ICU and wards, talk to your primary care staff, just even going up on the unit and performing surveillance while you sit there or going on interdisciplinary rounds. It helps to hear what's going on out there on the units. Surgeon and our patient surveys by mail or telephone are also a good mechanism for surveillance. And communication between facilities, because of course, if a procedure is performed at facility A, but then the patient goes to facility B with what looks to be an SSI, you'd really want to contact those IPs at facility A to let them know that there may be an SSI for their facility. So just make sure you have good communication between facilities. And then any combination of these surveillance methods that identifies all events are acceptable. So it really depends on what works best for your facility. And remember, do not rely only on wound cultures for SSI surveillance, because you're not going to get all your SSIs that way. You might get 50 to 60%, if that, of SSIs, but not all SSIs and the criteria are met using wound cultures. So remember that. Now that we talked about SSI reporting and surveillance methods, let's define what an NHSN operative procedure is. An NHSN operative procedure is a procedure that is included in the ICD-10, PCS, and/or CPT NHSN Operative Procedure Code mapping, takes place during an operation where at least one incision, including laparoscopic approach and cranial burr holes, is made through the skin or mucous membrane, or reoperation via an incision that was left open during a prior operative procedure, and takes place in an operating room defined as a patient care area that met the Facility Guideline Institutes, or FGI, or American Institute of Architects, or AIA, criteria for an operating room when it was constructed or renovated. This may include just a regular operating room, a C-section room, an interventional radiology room, or a cardiac cath lab. Note that otherwise eligible procedures that are assigned an ASA score of 6 are not eligible for NHSN SSI surveillance. So, operative procedure codes. NHSN uses the ICD-10, PCS, and CPT operative procedure coding systems. Operative procedure codes are used in healthcare settings as a way to communicate uniform information. Operative procedure codes allow NHSN to standardize NHSN SSI surveillance reporting and are required to determine the correct NHSN operative procedure category to be reported, although entering the operative procedure code into NHSN application is optional. Now, you will find all operative procedure code documents for 2019 under the Supporting Materials tab that is found on the SSI landing page. For the main 2019 guidance documents, a general definition is provided for each category, as well as a description for each individual procedure code. For FUSN, HPRO, and CAPR, there are supplemental guidance documents that are actually under supporting materials as well. We'll talk a little bit more about these. Additionally, ICD-10 CM diagnosis code document is found here and can be used to answer the diabetes question on the denominator for procedure form. So just remember, supporting materials is where you want to look for your operative procedure code documents. Now, operative procedure code documents are updated annually, and like I said before, 2019 procedure code documents should be used for procedures performed in 2019. Now, 2018 procedure code documents should be used for procedures performed in 2018. And again, these guidance documents from the past are found under the data validation page. Now, there are 39 NHSN operative procedure categories, with codes mapped to each of these categories. On the left-hand side, you can see here, there are screenshots of the 2019 ICD-10 and CPT code guidance documents. there is an individual category tab for all codes for each category. The screenshot on the right is Table 2 from the SSI protocol. It includes the 39 NHSN operative procedure categories available for SSI surveillance. Now, the former NHSN OTH or other category is not mapped to ICD-10 PCS and CPT NHSN operative procedure codes. And actually, this went away when we transitioned from ICD-9 to ICD-10. Another point I want to make is that sometimes we get questions about implants and implant field and how long do I follow procedures with implants. Well, the implant field was removed in 2003 actually, and so we don't actually provide guidance on whether or not an implant was in place. What we do provide it's determined the procedure surveillance period by Table 2, whether it's a 30-day or a 90-day surveillance period. We do appreciate feedback you provide us when the codes are posted, and if there is a need to post updates to codes, we do send this information out in a blast email. Now, in an effort to provide accurate information, we have made updates to the 2019 Operative Procedure Code documents that were originally posted in 2018 December. This was a blast email went out last week. I just want to mention that. The updates were communicated, but the updates will be included in the NHSN application with the release schedule for April 27th. So prior to the April 27th release, procedures assigned operative procedure codes that are included in the update can be entered using only the procedure category, as the codes will not be available until April 27th. And this update should be applied to all operative procedures performed beginning on January 1st, 2019. So let's talk about Denominator for procedure details. Now, procedure data must be in the application before an SSI event can be entered and linked. Procedure denominator data are collected using the Denominator for procedure form on the left-hand side here, as you can see. Both this form and the form that's on the right-hand side, which is the SSI event form, can be found under Data Collection Tools on the SSI landing page. Now, if your facility uses a vendor-provided system for data upload, remember to review the data for accuracy before it's uploaded into NHSN. So on the left here, you can see the Denominator for procedure form, and on the right here is the table of instructions document that's supplemental to the Denominator for procedure form. And basically what this is, it just goes through each of the data fields, and your instructions are basically defines how you would fill out that field. So I know we get questions sometimes asking about, oh, what does this field mean or what that, but oftentimes you can find the answer in the TOI document. So I just think just want to promote that as a resource to definitely go ahead and take advantage of the TOI. You do want to complete a Denominator for procedure record for every procedure meeting the NHSN operative procedure definition that was performed during that month if the procedure category is in your monthly reporting plan. Now, these are the various fields collected on that Denominator for procedure form. It's very important to get this information correct as these details are used for various risk adjustments and analysis. The purple highlighted fields will be discussed today, as these fields we do get some frequent questions about. The blue highlighted fields are supplemental data fields that are collected for those specific categories, and so we'll talk about those as well. But note that all fields are defined within that TOI document. So what is the difference between an NHSN inpatient operative procedure and an NHSN outpatient operative procedure? Well, an NHSN inpatient operative procedure is an NHSN operative procedure performed on a patient whose date of admission to the healthcare facility and the date of discharge are different calendar days. An NHSN outpatient operative procedure is an NHSN operative procedure performed on a patient whose date of admission to the healthcare facility and date of discharge are the same calendar day. Note that sometimes procedures that are billed as outpatient procedures actually meet the definition of an inpatient procedure. For example, a patient may have the billing status for an outpatient HIS procedure, but they may spend the night in an inpatient location. So actually for NHSN reporting purposes, that would be an NHSN inpatient operative procedure. So what is wound class? Now, wound class is the assessment of the degree of contamination of a surgical wound at the time of the operative procedure. There are 4 wound classifications: clean, clean contaminated, contaminated, and dirty infected. I want to really emphasize the point that wound class should be assigned by a person involved in the surgical procedure based on the findings of each case. NHSN does not endorse the IP going in and modifying the wound class or going through and trying to correct every wound class because they don't feel it meets the definition. So just pay attention to, if you do see an issue where, you could probably, go perhaps reach out to your OR and work through the issue, but just on a regular routine basis, we don't recommend you go and modify the wound class. This is really something that needs to be assigned by those that are involved in the actual surgical procedure. There are a few categories that can never be assigned as clean in the NHSN application, and those are as follows: API, Billy, Coli, Colo, Rect, Small Bowel, and VHIS. Now, the next detail I want to discuss is how does NHSN define emergency procedure? Well, emergency is a procedure that is documented per the facility's protocol to be an emergency or an urgent procedure. Whether or not a procedure is an emergency is dependent on how the facility documents the procedure, and this is often noted in the anesthesiology record or in the OR record. How is trauma defined? Well, trauma is defined as blunt or penetrating injury occurring prior to the start of the procedure. Complex trauma cases may require multiple trips to the OR during the same admission to repair the initial trauma. In such cases, you would indicate trauma equals yes. So, for example, if a patient falls down the stairs and fractures a hip that requires immediate surgical intervention to repair the fracture, this is an immediate trauma, and therefore trauma equals yes. Now, how does NHSN define scope? And FYI, I made a little bit of a tweak to this first bullet from the handout you received. So I wanted to make note of that. So the use of a scope involves creation of several small incisions to perform or assist in the performance of an operation rather than the use of a traditional large incision, which would also be known as your open approach. NHSN operative procedures performed using a laparoscope, you would indicate scope equals yes. ICD-10 PCS codes can be helpful in answering the scope question for you. The fifth character indicates the approach to reach the procedure site. We actually created new for 2019 a table within the protocol that actually indicates the character, the approach, and whether the scope would be yes or no. And we've tweaked this a little bit and expounded on this a little bit more within the procedure code FAQ document. CPT codes do not provide this level of detail. So for CPT codes, you would refer to the procedure code description to make this determination. I do want to mention that NHSN has removed the guidance that was formerly in the table of instructions for the denominator for procedure scope field. It read for CBGB, if the donor vessel was harvested using a scope, enter as scope equals yes. This guidance we have removed because this was really specific to the former ICD-9 coding system. So really, if a procedure is coded as an open and a scope, then the procedure should be entered into NHSN as scope equals no, because we feel that the open designation is considered a higher risk procedure. Okay. I want to move along to closure technique. This is another denominator for procedure detail. A primary closure is the closure of the skin level during the original surgery, regardless of the presence of wires, wicks, drains, or other devices or objects extruding through the incision. It's important to remember that if any portion of the incision is closed at the skin level by any manner, a designation of primary closure should be assigned to the procedure. If the procedure has multiple incisions or laparoscopic trocar sites and any of the incisions are closed primarily, then the procedure technique is recorded as primarily closed. There is also a non-primary closure definition, and this we define as the closure of the surgical wound in a way which leaves the skin left completely open following the surgery. The deep tissue layers may be closed by some means, with the skin left completely open, or the deep and superficial layers may actually both be left completely open. Wounds that have non-primary closure may or may not be described as packed with gauze or other material, or may not be covered with plastic, wound vacs, or other synthetic devices or materials. And here's just a picture I wanted to show you. On the left-hand side is an example of these three Incisions are actually a primary closure because, as you can see, a portion of the incision is closed at the skin level in some manner. And then on the right, two incisions are non-primary closures. The closure, this is a closure of the surgical wound in a way that leaves the skin left completely open. Note that wounds that are primarily closed can also have packing and wound vacs. If they close part of the incision and then place packing or a wound vac in the open part, this is still a primary closure. Both primarily closed procedures and non-primary closed procedures are entered into NHSN, into the denominator data for procedures and that you follow in your monthly reporting plan. And any SSIs attributable to these procedures are also entered into NHSN. There are no exclusions. Now I'm going to talk about those additional fields that are required for specific procedures. These are the C-section, spinal fusion, and hip arthroplasty and knee arthroplasty fields. I mentioned previously under supporting materials that there are some supplemental guidance documents for spinal fusion, a total knee, and total hip, and you'll find those under here. Additionally, we do have an additional field for C-sec, and I'll talk about that now. For the duration of procedure details, C-sec, the field information is collected on duration of labor. And we define this as entering the number of hours the patient labored in the hospital from beginning of active labor till delivery of the infant expressed in hours. Now, active labor may be defined by the individual facilities, policies, and procedures, but it should reflect the onset of regular contractions or induction that leads to delivery during this admission. Now, if a patient is admitted for a scheduled C-sec and has not yet gone into labor, the duration of labor would be 0. So there are additional details you'll find under that table of instructions form for duration of labor as well. And I just, by a show of hands, how many of you here actually perform surveillance for C-sec and enter that information into NHSN? Okay, good. So there's more than what I anticipated. So actually, we have some questions. We're trying to find facilities, preferably facilities that are larger facilities that perform C-section procedures. We have questions about data collection mechanisms and how well it works within your facility and what works for you, what doesn't work for you. So if you can find me at some point today or shoot me an email and put my name in the header to nhsn@cdc.gov, I'd like to talk with you about how you collect that data and what works best for you. So that would be great. Now, if an operative procedure is a fusion, you do want to check the appropriate spinal level and approach. It's a required field. If more than one spinal level is fused, you want to report the category in which the most vertebrae were fused. Now, the ICD-10 mapping guidance is provided to determine spinal level and approach and can be found under supporting materials. We do not have CPT spinal fusion approach guidance, and CPT codes do not offer this level of detail. You will have to review the operative report to make this determination. Now, for facilities performing HPRO and KPRO surveillance, you will need to indicate what type of HPRO or KPRO was performed. If the procedure is a total or a partial revision, you will need to indicate if the revision was associated with a prior infection at that index joint. You will find the prior infection at index joint document under supporting materials as well, and you use this document to determine if any listed ICD-10 PCS or CM diagnosis codes were recorded in the patient record 90 days prior to and including the date of the index revision procedure. More details can be found under the denominator for procedure TOI. Now, the SSI denominator for reporting instructions can be found starting on page 920 of the 2019 SSI protocol, and these instructions are in place to help users accurately report their procedure data. There are 11 denominator for procedure reporting instructions. I will be discussing a few of these that we get a lot of questions about. So denominator reporting instruction number 3 addresses different operative procedure categories during the same trip to the OR. If performed through the same or separate or different incisions, a denominator for procedure form is reported for each NHSN operative procedure category that's being monitored. Let me give you some examples. Let's say a patient has a card and a CBGC procedure performed during that same incision during the same trip to the OR. So a denominator for procedure report is reported for each. Also, a situation where a patient has an open reduction of a fracture or FX procedure and a splenectomy or spleen procedure performed during the same trip to the OR, and both procedure categories are being monitored within your institution, you would complete a denominator procedure form for each. The only exception to this reporting instruction is in a situation where a patient has both a coded CBGB and a CBGC during that same trip to the OR. You want to report this only as a CBGB. CBGB and CBGC are never reported for the same patient for the same trip to the OR. Denominator reporting instruction number 4 addresses duration of the procedure when more than one category of NHSN operative procedure is performed through the same incision during the same trip to the OR. You want to record the combined duration of all procedures. That means procedure start time to procedure finish time. Let me give you an example. A patient has a coloresection and also an abdominal hysterectomy during the same trip to the OR via the same incision. The time from procedure start to procedure finish was 3 hours and 30 minutes. So therefore, a denominator for procedure form is completed for the colo and another for the hyst. You would indicate the duration as 3 hours and 30 minutes on each form. Basically, the concept here is that the wound has been open the same amount of time. Therefore, the same amount of time is indicated on each form. There's the same amount of risk. Next is denominator reporting instruction number 8, and this reporting instruction addresses the same NHSN operative procedure category via separate incisions. So you would fill out separate denominator for procedure forms for procedures performed via separate incisions during the same trip to the OR for any of these 12 operative procedures. To document the duration of the procedures, you want to indicate the procedure start time to procedure finish time for each procedure separatively, or alternatively take the total time for the procedures and split it evenly between the procedures. And this would be if you don't actually have the time. If they didn't split it up and you can't make a determination, you would just take that total time and then split it evenly down the middle. Let me give you an example of this. So a patient underwent a bilateral K-Pro during a single trip to the OR. The left K-Pro procedure start time was 8:23 a.m. and procedure finish time was 9:50 a.m. The right K-Pro procedure start time was 10:03 a.m. and procedure finish time was 11:33 a.m. So what you want to do is fill out 2 separate denominator for procedure forms here. The left K-Pro with a duration of 1 hour and 27 minutes and the right K-Pro with a duration of 1 hour and 30 minutes. Does that make sense? Okay. Okay, so next reporting instruction is one that it's a very popular reporting instruction, and this is denominator reporting instruction number 9, and this addresses if more than one operative procedure is performed through the same incision within 24 hours. So if more than one operative procedure is performed through the same incision and the second procedure start time is within 24 hours of the first procedure finish time, you report only one denominator for procedure form for the original procedure. You combine the duration of both procedures based on the procedure start times and finish times for both procedures. Now, if the wound classes change, you want to report the higher wound class. If the ASA classes change, report the higher ASA class. And you want to assign the surgical wound closure technique that applies when the patient leaves the OR from the first operative procedure. So it's basically like we treat the second procedure as an extension of the first. And oftentimes, sometimes there can be cases where maybe there's a bleed or there's a complication and they have to return the patient quickly back to the OR. So this would account for that. Or maybe there's a delayed wound closure, so this would account for that. But it's 24 hours, and that's the cutoff. Now, if the second operative procedure is performed through the same incision at greater than 24 hours, it is a new separate operative procedure. So you would have a new denominator for procedure form. And let me give you an example. Now, Mrs. Green underwent a COLA procedure on 2/2 that began at 1 o'clock p.m. and finished at 3 o'clock p.m. And so it was a 2-hour duration. Now, on 2/3, Mrs. Green returned to the OR for another COLA procedure that began at 7 o'clock a.m. and ended at 9 o'clock a.m. for a 2-hour duration. Now, since the 2/3 COLO start time was within 24 hours of the 2/2 COLO finish time, you report one denominator, and that's for that 2/2 COLO. You follow the 24-hour reporting instructions for procedure details. You do not report the 2/3 COLO procedure. Does this make sense to everybody? Okay. Okay, the last final reporting instruction that I want to discuss is Denominator reporting instruction number 11, and this addressed HIS and VHIS procedures. We did update verbiage for 2019 to reflect that hysterectomy procedures that involve an incision into the abdomen, including a trocar incision, are categorized as NHSN HIST, abdominal hysterectomy procedures. A few of the CPT codes that include laparoscopy, surgical, and with vaginal hysterectomy in the procedure description are now included under the HIS procedure category. The decision was that the use of a laparoscopic approach indicates that an incision was made into the abdomen. Therefore, we put these procedures under the HIS category. And this is just a table of showing you what 4 CPT codes are now under the HIST category that were previously VHIST procedures, because they do include a laparoscopic approach. It was difficult to determine how the uterus is detached from its supporting structures based on review of op notes. So we made the decision with NHSN leadership to include hysterectomy procedures with an abdominal incision under the HIS category. Okay, so now that we've completely went through several of the denominator reporting instructions and details, we're going to move on to the numerator information, or the SSI event information. And we'll start off with just the basic SSI definitions. I want to say there was no significant changes for 2019. There was some tweaking of words for deep incisional SSI criterion B, but it wasn't changing what the message or the meaning of it was, just to try to make it flow a little easier. So we'll go ahead and we'll get started. There are 3 tissue levels that are defined within the SSI protocol where SSI criteria can be met. And that first is your most superficial tissue level. A superficial incisional SSI must meet the following criteria. The date of event occurs within 30 days after any of the 39 NHSN operative procedure categories where day 1 is the procedure date, and involves only the skin and subcutaneous tissues of the incision, and the patient has to meet at least one of the following, just one, and one criterion doesn't depend on meeting another. So I just wanted to make that clear. So the first is A, purulent drainage from the superficial incision. B would be organisms identified from an aseptically obtained specimen from the superficial incision or subcutaneous tissue by a culture or non-culture based testing method. C is superficial incision deliberately opened by a surgeon, attending physician, or other designee, and no culture is performed, or no non-culture based testing is performed. And the patient must have a qualifying sign or symptom. So to meet C, basically, there can't be a culture performed. If there was a culture performed, positive or negative, you wouldn't apply criterion C. I just want to make that clear. And then on D is a diagnosis of a superficial incisional SSI by a surgeon, attending physician, or other designee. And this diagnosis criterion only lives in the superficial SSI criteria. There are 2 types of superficial incisional SSIs. There's superficial incisional primary and there's superficial incisional secondary. A superficial incisional primary is an SSI that is identified in the primary incision in a patient that has had an operation with 1 or more incisions. For example, a C-section incision or a chest incision for a CBGB. There are 7 NHSN operative procedure categories that have a secondary incision site available for SSI attribution. And this is when you would, if it's a superficial incisional secondary, this is when you would apply this. A superficial incisional SSI that is identified in the secondary incision in a patient that has an operation with more than 1 incision. For example, if it was a CBGB procedure, this would be the donor site incision. And if an SSI sets up here, then that would be a superficial incisional secondary SSI event. Now, the appendix at the back of Chapter 9, and I'll show that in a bit, lists every NHSN operative procedure category and which of the procedure categories have secondary insights. So we have that all figured out for you. You don't have to try to figure that out. There are reporting instructions for superficial incisional SSI. Let me highlight a few that we get questions about. So in terms of a stitch abscess alone, we don't consider this as an SSI. This is defined as minimal inflammation and discharge confined to the points of suture penetration. But if the stitch abscess involves the incision proper, or perhaps it progresses to a deeper tissue level, then this needs to be investigated as an SSI. Additionally, a laparoscopic stab wound or a pin site infection is not considered an SSI. Depending on the depth, these can be looked at for maybe meeting HAI skin or soft tissue, but these would not be considered an SSI. But if the surgeon uses a trocar site to place a drain at the end of the procedure and the trocar site develops an infection, then you do need to investigate this as an SSI. For an NHSN operative procedure, a laparoscopic trocar site is considered a surgical incision and not a stab wound. As a reminder, superficial incisional SSIs are followed for 30 days, regardless of what the procedure is. Secondary incisional SSIs for deep and superficial are also only followed for 30 days. Now let's move on to deep incisional SSI criteria. So deep incisional SSI criteria is defined as must meeting the date of event between 30 or 90 days after the NHSN operative procedure category, where day 1 is the procedure date. And this would be according to the list in Table 2, how long you surveil that procedure for. It involves deep soft tissues of the incision. So for example, it could be the fascial or muscle layers, and must meet one of the following. A is purulent drainage from the deep incision. B is a deep incision that spontaneously dehisces, or is it deliberately opened or aspirated by a surgeon, attending designee, or other physician or other designee, and organism identified from the deep soft tissues of the incision by culture, non-culture based testing, or no culture, non-culture based testing is performed. Now, if they perform it and it's negative, you cannot apply criterion B. And the patient has to have at least one qualifying sign or symptom: fever, localized pain, or tenderness. Criterion C is met if an abscess or other evidence of infection involving the deep incision is detected on gross anatomic or histopathic exam or imaging test. For criterion B, I wanted to point out that organisms have to be identified from the deep soft tissues. We're referring to deep incisional SSI criteria here. We've had some cases before where users have taken a superficial culture and applied it, or organ-space culture and applied it. But no, this is very much so specific to the deep soft tissues. So the organism has to be identified from the deep soft tissues to apply. And again, just like superficial incisional SSI, there are secondary incision sites for deep incisional secondary, same procedure categories, and basically an SSI can set up in the deep soft tissues of those secondary incision sites, and they're available for SSI attribution. Taken from Table 2 in the SSI protocol, I just want to point out that the 90-day surveillance only applies to those procedures here for deep and organ-space SSI events. Of course, if any of these procedures, for example, a breast procedure has a superficial SSI, those are only followed for 30 days. Now let's move on to the deepest tissue level involved that can be involved in an SSI, and that's organ space. In order to meet organ space SSI criteria, the date of event must occur within 30 or 90 days after the NHSN operative procedure, where day 1 is the procedure date, according to the list in Table 2, and involves any part of the body deeper than the muscle fascia layers and that is open or manipulated during the operative procedure. And the patient has to have at least one of the following: purulent drainage from a drain that is placed into the organ space. This could be a closed suction drainage system, open drain, T-tube drain. Maybe there's a CT-guided drainage. B would be organisms identified from fluid or tissue from the organ space by culture, non-culture-based microbiologic testing. And then C is an abscess or other evidence of infection involving the organ space that is detected on gross anatomical or histopathic exams, such as like a path report, or imaging test evidence that suggests infection. But we don't stop there. You also have to meet one criterion for a specific organ space infection site listed in Table 3. So you have to actually meet one of the definitions that is outlined in Chapter 17 for that specific type of infection. So as you can see here, we have to meet A, B, or C for organ space SSI, but additionally, you also have to meet one of the site-specific criteria that's available for SSI attribution following that procedure category. So Table 3 in the SSI protocol lists the specific sites eligible for organ space SSI citation. And these are defined in Chapter 17, their definitions. And this is the appendix that I was talking about in the back of Chapter 9. This is just basically goes through all 39 NHSN operative procedures and shows you what specific event types can be assigned to that procedure category. It used to be that you would only know by going into the application and then going to the drop down. and then making a determination that way, well, that was a little bit cumbersome. So this table was put together to show users that, okay, for example, following an AMP procedure, the patient could have a superficial incisional SSI, a deep incisional SSI, or they can have a joint or a bone assigned to that procedure category. Next, I will highlight important SSI event details and reporting instructions that can be found within the SSI protocol and SSI FAQ document. Now, there are 11 SSI reporting instructions that begin on page 913 of the SSI protocol, but we're going to address some of these here and then some of these in our knowledge checks, but we're not going to be able to go through all these because, we don't have all day. But we're going to go through some of the ones that are important and that we get questions about. And as a reminder, and this has been addressed throughout the week, but the SSI protocol is located in the procedure associated module, and it has its own definitions for classifying infections. So there is no infection window period, POA, HAI, none of that applies. Repeat infection time frame, none of that applies to SSI surveillance. SSI use, we do have a date of event and we do have a secondary BSI attribution period, but the SSI protocol has their own definitions for that. So I just wanted to remind you of that. The SSI is really based on surveillance periods, a 30-day or a 90-day SSI surveillance periods. So since SSI has a 30 or 90-day surveillance period, depending on the procedure category and level of infection, one of the questions we get, does each trip to the OR via the same site start a new surveillance period, or perhaps does that patient still remain in their surveillance period, for as long as it goes? Well, the answer is generally each return trip to the OR via the same site ends the surveillance period from the prior infection or the prior procedure and resets the new surveillance period. SSIs are normally attributed to the most recent trip to the OR. I will say there are instances where a patient can go to the OR multiple times and they may have multiple opportunities for SSI citation, depending on how the procedures are coded. So what is the date of event in terms of SSI surveillance? Well, this is the date when the first element used to meet the SSI infection criterion occurs for the first time during the SSI surveillance period. The date of event must fall within the SSI surveillance period to meet SSI criteria. And the type of SSI, whether it's superficial incisional, deep incisional, or organ space reported, and the date of event assigned must reflect the deepest tissue level where SSI criteria is met during that surveillance period. All elements required to meet an SSI criterion usually occur within 7 to 10 days, with no more than 2 to 3 days between elements. But again, this may vary. There is no IWP for SSI surveillance. So it's really going to be dependent on the individual case and what makes the most sense. The elements have to be relational to one another. You want to ensure that the elements all associate to the SSI, and this can only happen if elements occur in a relatively tight time frame. So each case, like I said, differs based on the individual elements occurring in the type of SSI. So it wouldn't make, like as an example, a patient has a HIS procedure, post-op day 5, they have a fever, one documentation of fever, and then post-op day 25, they meet other elements for SSI criteria. Well, it just doesn't make a lot of sense to grab that fever and then go to day 25 and say that they're relational if it's not continuing or if there's not some kind of, clustering of symptoms. I mean, you just have to, it just depends on each case and it has to make sense. So let me give you an example. And actually, this is our first poll everywhere. So everybody get your cell phones out. This is regarding date of event. We have a patient that had a colo procedure on day 1. On day 6, they meet criteria for a superficial incisional SSI. That's their date of event. And on day 25, they make criteria for an organ space SSI as their date of event. So the question is, what is the date of event for this SSI? What would you report? Is it day 1, when the colo was performed, day 6, when they met superficial incisional SSI, day 25, when they met IAB SSI, or do you actually report 2 events here because they meet both superficial and organ space criteria? All right. All right, I'm going to show correct here. So the correct answer is actually C. So good job. This is your date of event for meeting your organ space IAB SSI, and this is what gets reported. And the rationale is you only report one SSI event for a procedure of the primary incision site, and day 25 is your date of event. Day 25 reflects the deepest tissue level where SSI criteria are met during the SSI surveillance period. Does this make sense? So remember, you can't have 2 SSI events assigned to that colo. It has to be one, and since the deepest tissue level was the organ space level, you met criteria, that's when you would assign this event as an organ space SSI. Okay, now there are 2 scenarios where blood specimens can be deemed secondary to an SSI. The first scenario is when at least one organism from the blood specimen matches an organism used in meeting SSI criteria. And let me give you an example. The patient meets the criteria for a deep incisional SSI, criterion B. Staph aureus is isolated from a deep tissue culture, and the patient also has a blood culture matching the Staph aureus as well, and the blood culture falls within the secondary BSI attribution period. This would be scenario 1. Scenario 2 is actually when an organism is identified in the blood specimen, and it's an element that is used to meet the SSI organ space site-specific infection criterion. And as an example for this, we would, for example, would be IAB criterion 2B or IAB criterion 3B, where you actually use blood as an element. Blood is actually part of the definition. So this would be an example for scenario 2. Scenario 2 would only be applied in a situation where you're working with an organ space SSI and you're working with chapter 17. Does that make sense? It would just have to be, the blood would be part of a definition in chapter 17, and that's how it's used as an element. Scenario 1 can be applied to superficial, deep, or organ space. Let me give you a picture here of how to apply scenario 1. This is just an example. The secondary BSI attribution period for SSI includes your date of event, which is day 13. You have 3 days prior and 13 days after for a total of 17. This is your scenario 1. This is your 17 days where you can have that matching blood fall here and then assign it and say it's secondary. Let's look at another FAQ, a question that we get sometime, and this is aseptic technique. Users ask, what is an aseptically obtained culture? So how we define this is they're specimens obtained in a manner to prevent introduction of organisms from the surrounding tissues into the specimen being collected. Now, culture results of mixed flora or mixed cutaneous flora alone cannot be reported to NHSN as there's no such pathogen option in the list of pathogens. But you may have to actually work with your lab to review proper technique based on your facility lab protocol if you're seeing a lot of these type of culture results. And are common commensal organisms excluded from meeting SSI surveillance? And the answer is no. There are no excluded organisms in SSI surveillance outside of those excluded organisms that are found in Chapter 9 SSI Protocol, Numerator Reporting Instruction number 1 on page 914. And Kathy did review these on Monday. Note that organisms that are identified from broth only are not excluded. Sometimes we have users that think these should be excluded, but no, they're not. Such media can be enriched to identify organisms that might otherwise not be detected. And SSI surveillance is based on surveillance definitions. We don't judge organisms based on whether it's a contaminant or deemed not clinically significant. We'll get questions about this and say, oh, you know, it was brushed off. They feel like it's a contaminant. That wound specimen, it doesn't mean anything. Well, we don't judge on that. It was isolated. It's eligible. It's a pathogen available in the drop-down menu. These are surveillance criteria and definitions, so it would be used to meet. Another question that we get questions about from time to time is gross anatomical exam. And this is actually a key term. Gross anatomic exam is defined as evidence of infection elicited or visualized on physical examination or observed during an invasive procedure. It could be during admission or subsequent assessments of the patient and may include findings noted during a medical invasive procedure dependent upon the location of infection as well as the NHSN infection criterion. Some examples that we have. An intra-abdominal abscess will require an invasive procedure to actually visualize the abscess. That's the key. They have to actually see it. That's gross anatomic. Visualization of pus or purulent drainage, including that from a drain, that's gross anatomic. For SSI only, and again, I repeat, SSI only, abdominal pain elicited on physical exam post a C-section or a hysterectomy procedure is sufficient evidence to meet general organ space, criterion C. Not site-specific, but just your general organ space C. And then it allows you to move on to site-specific criteria. Allowing abdominal pain elicited on physical exam as gross anatomic evidence of infection does allow you to move on to site-specific. Otherwise, for example, OREP criterion 3B, there is not, this would be difficult to apply organ space criteria without having a culture or, imaging test. So that's why we allow just specifically for these C-sec and HIS procedures, pain to meet general organ space criterion C, because they may not return to the OR where they may see anything on gross anatomic exam. Imaging test evidence of infection cannot be applied to gross anatomic exam because it's not gross anatomic exam. Imaging test evidence has distinct findings found in the HAI definitions. So now what about purulence? Do we have a definition for purulence? No, we don't. NHSN does not define purulence as there is no standard clinically agreed upon definition. Documentation that includes descriptors such as thick, viscous, creamy, opaque, or pus purulence would be accepted evidence of purulence. NHSN does not, we don't use gram stain results such as WBCs or PMNs to define purulence in the SSI protocol. Of course, if you have a question about does this term meet purulence, definitely email us and we can take a look at it with you. Now, clinical correlation is a definition that you'll see in Chapter 17. So this would be like if you're applying an organ space SSI event. This is defined as physician documentation of antimicrobial treatment for site-specific infection. It is used, for example, with IAB or GIT criteria when there's equivocal imaging findings. So if the imaging findings aren't really definitive for an abscess or abscess versus this versus that, that's an instance where you would actually need clinical correlation. So you're going to need specific physician documentation of treatment for that specific type of infection to apply this criteria. And again, this is defined in key terms. So all these definitions are in your frequently asked question documents, your key terms, your table of instructions. You're going to find all that there. Now, I think the most important event detail of the day is PATOS, because we get questions about PATOS a lot, and PATOS is very popular. So let's talk a little bit about PATOS. PATOS is actually an SSI event reporting instruction, and it's number 3. And what this is, it's a yes/no field on the event form only. Event form only. And it's only considered, you only answer the PATOS question if an SSI criteria is met within the surveillance period following that NHSN operative procedure. It is not a data field on the denominator for procedure form. You don't even think about PATOS with the denominator form. It's only addressed if an SSI criteria is met following an NHSN operative procedure within that appropriate surveillance period. Again, it's a required field on the SSI event form. And what it is, it denotes that there is evidence of infection or abscess that's actually seen during the index operative procedure. In other words, present preoperatively, and it's documented in the intraoperative note or immediate post-op note. So oftentimes, we get questions about what would be. We don't have a list. We can't possibly put a list together of what would meet PATOS or infection evidence. But a lot of times, what you're going to see is you're going to see abscess, you're going to see purulence, pus. Those are the kind of terms that we're looking for. Terms such as colon perforation, that's not evidence of infection. And maybe that's a complication. Maybe there's fecal spillage, but that's not infection in and of itself. Necrosis, gangrene, that's dead tissue. A nick bowel, inflammation, certainly has the opportunity for infection to set up following the procedure, but at that time, that is not infection seen. So really, it's the abscess, it's the purulence, it's the pus. Those type of terms is what we're looking for. You want to only select PATOS equals yes if it applies to the depth of SSI that is being attributed to the procedure. Let me give you an example. If a patient has evidence of an intra-abdominal infection at the time of surgery, and then later returns with an organ space SSI, you would mark the PATOS field as a yes. Now, if the patient returned with a superficial or deep SSI, your PATOS field would be no, because it's not the same tissue level. Here's a frequently asked question that we get. Where within the patient medical record can I find the documentation I need to answer the PATOS question on the SSI event form? Well, if you were listening, the PATOS response, yes, no, is determined by evidence of infection documented in the op procedure report only. It's commonly noted in the narrative of the op report, and that's where we really want to be seeing it. The language verbiage in the op report must clearly reflect that infection is seen during the procedure and should additionally include reference to the tissue level where it is seen. Note that wound class cannot be used to answer PATOs, progress notes, path reports, wound cultures. None of those are eligible for answering PATOs. It has to be, we need to actually have them seeing and visualizing and documented as such. Another question, if a patient has an SSI and it is found to meet criteria for a PATOS equals yes, do I need to enter this SSI into NHSN? Why even bother, right? Well, the answer is yes. That's very important information for us to have and for you to have, and you need to enter those PATOS equals yes events into NHSN. They are not excluded for reporting. Maybe they are not furnished on to CMS, but that information is something that we track and we trend, and it's very important information to have. So you have to report those PATOS equals yes SSI events to NHSN. There is an SSI PATOS Quick Learn that is available. It's about 6 minutes. That's available under the Training Resources tab on that landing page, just for those that maybe haven't seen it or want to know more information about PATOS. And let me give you a couple examples here. On 2-1, a patient presents to the ED with an acute abdomen and goes directly to the OR for a colon resection. A peritoneal abscess is documented intraoperatively and drained, and a thorough abdominal washout is performed. The incision is loosely closed with some packing between staples, and a JP drain is placed in an adjacent stab wound. Now, on 2-4, the patient's doing pretty well and is discharged home. On 2-8, the patient presents to the ED with fever, abdominal pain, and an abdominal CT is performed. The abdominal CT identifies a left lower quadrant abscess with a subsequent CT-guided drainage of the abscess that identifies E. coli. So this is reported as an SSI IAB, meaning IAB criterion 1, and the PATOS field would be entered as a yes. There you go. This is why. Because originally in that first operative procedure, they note a peritoneal abscess. That's the organ space level. And then 2-8, they come back and they have this abscess identified. PATOS equals yes there. It was present at the time of surgery at the organ space level. Okay, so this is basically the same scenario, but slightly tweaked. Patient goes to presents to the ED, goes to the OR for a colo, peritoneal abscess is documented intraoperatively and drained, and a thorough abdominal washout is performed, loosely closed, some packing between staples, and a JP drain is placed in an adjacent stab wound. Patient goes home on 2-4, doing pretty well. On 2-8, they come back with purulent drainage from their deep incision. This is reported as an SSI deep incisional primary, meaning deep incisional criterion A. The PATOS field will be entered as a no. Why? Because the patient came back with an SSI that's set up at the deep tissue level, not the organ space. So this would be a PATOS equal no. Okay. Okay, I think we have a little more time. So what I'll do is I'll go ahead and get started. We're actually doing pretty good on time. I was a little afraid that we would not be doing pretty good on time, but we are doing good. So I think what I'll do is now basically what we have here are our knowledge checks. So we took all of our information. You have your denominator information, you have your numerator information, and now we're going to try to apply some of that information throughout knowledge checks where you would use the poll everywhere. So we'll go ahead and we'll get started on a couple of these, and then break at, I believe it's 9:30. So what I wanted to start out just addressing the SSI FAQ question number 1. And I think we've addressed this the past couple of years at annual training. But the question is, what can the user provide to NHSN for a complete SSI case review request? I just wanted to highlight this because sometimes we get questions that aren't that may have limited information in the email, or maybe the user just doesn't know what to provide. But so we thought by putting together some different elements here that it may help the user sort of kind of move them along to figure out what type of pieces of information they need to pull from to gather and then put together in an email to provide to NHSN so we can best help you. So our turnaround time is faster, and so we could have the most well-informed information to provide you a response. Because sometimes we get emails with just missing information, like without knowing if it's an NHSN operative procedure, or not knowing the tissue levels involved in the infection, or maybe they went back to the surgery multiple times, but that we don't know that, and that was information that came out later. We really need to know everything as much as we can up front. And also sometimes I get questions from users where there's like cultures that are still pending, and they want an answer. And we really prefer to have all the complete case details in front of us to be able to provide you the best response that we can give you to be as most accurate as possible. So here's some examples of some of the elements that we would be looking for. Operative procedures and date of all operative procedures, including reoperations. They are all important if they have to do with your question at hand. I mean, not necessarily a procedure from years ago that is not relevant. We want to know of all the operative procedures, how many times they went to the OR, and if those are NHSN operative procedures. That's really important information to know. Now, if it is a return to OR, like we talked about that 24-hour rule, if you can determine the procedure start time and finish time for both procedures, that would really help us knowing, if it's one procedure, or if it's two separate procedures. Looking at that, signs and symptoms. So really just combing the chart and looking ahead to determine any kind of signs and symptoms that may be relevant and tissue levels involved. So superficial, deep, and organ space. If they're going back to the OR, how deep do they go in when they went back into the OR? If they've collected culture, what tissue level was that culture from? This all helps. Imaging tests performed and described. Dates of any imaging, what were the findings? Were there any fluid collections noted, or did they perform any sort of drainage? And if it was, how did they describe that drainage? Did they culture it? Culture results. So what site was the specimen collected from? And then also the depth it was collected from, and any other evidence that you may have that would support citation of an SSI or help us with making that determination is really incredibly helpful, and putting that in chronological order. So it's just easiest that way. And again, don't include any patient identifying information. Don't include any patient birth dates, names, things of that, because we have to delete that immediately. And then you'll have to just resend the case. We'll ask you to resend the case to us. We cannot receive emails with the patient identifying information in it. Okay. So we'll go ahead and we'll get started on scenario 1. On 11/1, we have a 43-year-old Mr. Green was involved in a motor vehicle collision and underwent emergent exploratory laparotomy, an XLAP procedure, and a colectomy, so a COLA procedure. The operative report stated blunt colonic perforation with gross fecal contamination. At the conclusion of the procedure, it was noted that the skin was loosely approximated with staples and a wound vac was applied to the incision. Now, on 11/5, while in the hospital, the patient began to complain of a hot incision site. The MD removed 2 staples and opened the incision up and probed the superficial wound. No cultures were performed, and the patient was then started on antibiotics. He looks very happy, actually, in that picture. I don't know. I chose the wrong picture. What is the closure technique that should be assigned? Would this be a primary closure or a non-primary closure? All right. All right, we're going to show the correct answer, and the correct answer is primary closure, A. People can change their answers. Is that going to start going down? No. Okay, so you're correct, absolutely, great job. This would actually be assigned as a primary closure, and the rationale is that portions of the incision are closed at the skin level. If any portion of the incision is closed at the skin level, by any manner, a designation of primary closure would be assigned to the surgery. Now, knowledge check number 3. The operative report states blunt colonic perforation with gross fecal contamination. What wound class should the IP recommend be assigned in this instance? Is it a clean contaminated, dirty infected, or the IP should not recommend assignment of wound class? You were listening. No. All right, I'm going to close this out. Show. Huh. Okay, we're just going to go to the next page and I'll tell you what's right. Okay, so the correct answer is E. The IP should not recommend assignment of wound class. Wound class should be assigned by a person involved in the surgical procedure based on the findings of each case. We don't endorse the IP going in and modifying the wound class after it has been assigned. And like I said before, like if there's issues with it, of course, that's something that you could work through within your facility in your OR, but just on a routine basis, you shouldn't be going in there and trying to modify or change the wound class. That's really up to the surgical team to assign. Okay, so looking back at your case, does everybody, yeah, everybody mostly has your case in front of you. What SSI criteria is met? Would it be helpful if I go back to the case? All right. Bear with me here. Let me let you read it one more time. So the question is, what SSI criteria is met? All right. So I'm going to actually have to move back forward. So if you have your handouts in front of you, you might want to refer back to that. Okay. Let's see. Okay. Well, the answer is this meets superficial incisional criterion A. Why did that do that? What in the world? All right, hold on here. Wait, so okay. That's strange. Hold on. So this is not the question that you have? The pull everywhere is wrong. Like it's, okay, I get it. All right, let's look. Okay, the answer is C. Okay, that's, sorry about that. Let's look at why. Okay, so it's a criterion C. So, well, first of all, the date of event occurred within 30 days, superficial, 30 days only. It involved the skin and subcutaneous tissues of the incision. And criterion C is met because the incision was deliberately opened by the physician, as well as the patient has a qualifying sign or symptom, which was that heat at the incision site. Trauma equals yes does not exclude reporting the procedure nor the SSI event. Trauma field on the denominator form is just used as a risk adjustment, but it's not an exclusion. You have to report the SSI event. Okay, so what procedure gets the SSI attribution? Would it be the XLAP, COLO, or this isn't even SSI? Well, we know it's an SSI, but I put that in there originally so when you didn't see it ahead of time. All right. Kind of have an overwhelming response. All right. Okay, so the correct answer for this is B, COLO. And let's take a look here. And the rationale is because the procedure attribution is not clear. I mean, it's a superficial incisional SSI. It's really, it's not clear. So you want to use the NHSN Principal Operative Procedure Selection List, which is that table 4, to select which operative procedure to which the SSI should be attributed. So this is what that table 4 is in the SSI protocol. As you can see here, COLO is above XLAP in terms of a risk level. So it would be assigned as to the COLO. And this goes along with reporting instruction number 9 that I've highlighted here. Okay, I think we could probably do maybe one more scenario. Okay, scenario 2. On 6/5, Mrs. Blue was admitted to the facility and underwent a HIS procedure. The patient had an ICD-10 code assigned as follows. On 6/6, Mrs. Blue was discharged. But on 6/14, she was seen by her surgeon for a post-op checkup. Mrs. Blue noted that her incision site had become red over the past couple of days with some slight drainage. The surgeon dictated that she observed serous-colored drainage from Mrs. Blue's superficial incision site and collected a culture of the drainage. Antibiotics were prescribed, and Mrs. Blue was sent home. The culture results staph epidermidis on 6/16. So the question is, how would you answer the scope field on the denominator for procedure form? So here, okay. Okay, so the correct answer is scope equals yes. That is B. I don't think it wants me to leave this slide. Oh. All right, here we go. And the rationale is because, remember that little table I showed you? That fourth character, or the digit here is 4. So therefore, it would be a percutaneous endoscopic approach, and you would say scope equals yes. Now, does Mrs. Blue have an SSI? Again, you would want to refer to your slides at the scenario, but yes, superficial incisional SSI criterion A is met, criterion B is met, criterion C is met, or no, SSI criteria is not met because the organism isolated is common skin flora. So the options are superficial A, B, or C, or no, it's common skin flora. And this is the scenario. All right, let's go over there. All right. Okay, so the correct answer is B. Yes, superficial incisional SSI criterion B is met. So we know that the SSI event occurred within 30 days of the operative procedure. It involved only the skin and subcutaneous tissues of the incision, and there were organisms identified from culture. Staph epidermidis. Again, even if considered a common skin flora or this is an organism that's still eligible for SSI attribution. So it's not an excluded organism in terms of SSI criteria. Remember, organisms are not judged on contaminant or common commensal. If the organism is identified, it is to be reported. Good job. You know, I think I want to do is go ahead and maybe take a break here because I don't want to stop in the middle of a scenario, if that's okay. Is that okay?